Welcome everyone. Please enjoy our teaching presentation on gestational diabetes, presented by Tiffany Gooden, Mandy Hamilton, and Christine Legg. To introduce Emily, she is 39 years old and is married to Chuck. She is a Gravida 3 Para 2 Caucasian woman who has had no past pregnancy complications. She does have a family history of type 2 diabetes, and she has hypothyroidism, which she has managed well before becoming pregnant. She is now 28 weeks gestation and has just been diagnosed with gestational diabetes. Emily and Chuck are both very interested in learning about gestational diabetes and what that means. They express interest in learning about blood glucose monitoring, medication needs, and changes in nutrition and exercise. With her diligent monitoring of hypothyroidism, Emily is also concerned about pregnancy-related changes in her current regimen. For our teaching specifics, we will teach Emily and Chuck about monitoring and medications needed with gestational diabetes. We will also teach about nutrition and exercise and changes to hypothyroidism in pregnancy. We will provide this teaching at the Good Hamilton Legg OBGYN clinic at each visit and throughout pregnancy. We do believe in follow-up phone calls, so we'll follow up with Emily and Chuck in this manner. And we want to do this so that we can reduce complications associated with gestational diabetes, both maternal and fetal, and improve outcomes. Our methods of teaching will include both verbal and written instructions, as well as return demonstrations on blood glucose checks and insulin injections.
In order for Emily and Chuck to get a thorough understanding of her diagnosis, we need to teach them what gestational diabetes mellitus is. We cannot assume that Emily understands the ins and outs of her diagnosis just because of her familial history. Perry, Loudermilk, Cashin, and Alden explain that the pancreas produces insulin from the beta cells in response to glucose in the blood. It is insulin that allows this glucose to enter the fat and muscle cells to be used for energy. When there isn't enough insulin or it isn't effective at moving that glucose, hyperglycemia or high blood sugar is the result. Too much glucose in the blood creates too many solutes or hyperosmolality, and that will pull water from the cells and increase overall blood volume. The body will naturally attempt to rid the extra volume with excessive urination or polyuria. This polyuria and cellular dehydration causes increased thirst, polydipsia. Since the body is not using the glucose as intended for energy, fat and muscle cells are broken down instead. This makes the body think it is starving and causes the individual to eat excessive amounts of food, or polyphagia. Since the body is eating more food, the glucose levels continue to rise and the cycle begins again. Because of Emily's diagnosis of gestational diabetes, she is at risk for a few complications of her own. Loss of a normal pregnancy is one of them, and this is because of the need for frequent blood glucose monitoring, changes in her diet and exercise, and medication management. Increased risk for cesarean section and assisted delivery, such as forceps or a vacuum, is also of concern related to a larger baby or macrosomia. The surgery itself comes with a longer recovery time, increased pain, and an increased risk of infection. Now, because insulin does not cross the placenta, but glucose does, there is a higher osmolarity in the amniotic fluid. And just like the blood volume increasing in Emily's vascular system, the amniotic fluid around the baby also increases. This is called polyhydramnios, and it can lead to placental abruption, uterine dysfunction, and postpartum hemorrhage. Emily is also at greater risk of developing type 2 diabetes mellitus just because of her gestational diabetes diagnosis. Breastfeeding longer than 6 months can decrease that risk overall. Emily and Chuck also need to be aware of the potential effects of the baby. Macrosomia can cause shoulder dystocia at birth or birth traumas purely because the infant's size. The infant also has higher chances of obesity later in life. Now, because the fetus has a constant supply of sugar while in the uterus and is used to making large amounts of insulin, hypoglycemia is of major concern after birth. We have just taken away their constant supply of sugar, but their pancreas is still making insulin and bringing those blood sugars way down. This could require additional monitoring in the NICU until the baby is stable. Bringing those complications to the attention of Emily is important during her new diagnosis of gestational diabetes mellitus. Hilliard, Kaysen, Sinclair, and Murphy mentioned that lifestyle changes during pregnancy are more likely to take place due to the mother's concerns over her health and that of the babies. These authors compiled data and determined that diet and activity during pregnancy with gestational diabetes has reduced the need for insulin and cesarean births. At the Good Hamilton Lake Clinic, we suggest women with gestational diabetes mellitus to adhere to the dietary approaches to stop hypertension, or simply the DASH diet. Fruits, vegetables, whole grains, and low-fat dairy are the staples of this eating plan, while avoiding foods containing saturated fat and cholesterol like sweets and refined grains. We also recommend activity to reduce the need for insulin. 3 days a week of activity can include walking, aerobics, or home-based workouts.
It will be important for Emily to have strict control of blood glucose levels to prevent complications. She will be instructed on the use of a blood glucose monitor, and this will be reviewed with a return demonstration to be sure that she can use it correctly. According to Perry, Loudermilk, Cashin, and Alden, blood glucose should be checked at the following times: first thing in the morning, 1 to 2 hours after breakfast, before and after lunch, before dinner, and right before bed. All results should be kept in a log and should be brought with her to every prenatal appointment. If blood glucose cannot be maintained by diet and exercise, then medication may be prescribed. There are typically 2 oral hypoglycemics used for gestational diabetes, glyburide and metformin, and both appear to be safe and effective in pregnancy. Metformin increases sensitivity to insulin, and glyburide causes the pancreas to produce more insulin, and the physician will determine the best medication. An ideal fasting goal for blood glucose is 60 to 105. 1 hour after a meal is less than 140. 2 hours after a meal, less than 120. And if these goals cannot be maintained by oral medication, insulin may be required. There are several different types of insulin that are used based on the time it takes for maximum effect. Proper handling will include instruction for washing her hands and demonstrations on how to properly withdraw the correct amount of insulin and how to inject it. And insulin may be needed multiple times a day based on blood glucose levels.
Emily has managed her hypothyroidism well since her diagnosis. Kashi, Bahar, and others suggest that this indicates a better outcome during pregnancy. We will explain that thyroid function is affected by pregnancy as the body compensates for the growing baby. The baby will make his or her own thyroid hormones at 18 weeks of gestation. TSH levels will be drawn more frequently than Emily is accustomed to, and levothyroxine may need to be adjusted to allow for strict maintenance of TSH at or below 2.5 milligrams per deciliter. Perry, Loudermilk, Cashin, and Alden suggest increasing levothyroxine dosages by 25 to 50 micrograms every 4 to 6 weeks to maintain TSH levels. Emily should be taught to monitor for increasing fatigue, which may indicate anemia, and to be watchful for signs of preterm labor, as these are risks associated with hypothyroidism in pregnancy. We will be watching her blood pressures at each visit to monitor for hypertension, and we will explain the risk of postpartum hemorrhage. We will teach Emily to take her levothyroxine at least 4 hours apart from iron, because iron will decrease the absorption of levothyroxine. Throughout the antepartum period, the goal is to maintain strict blood glucose control, as this will reduce complications. During labor, hourly checks will occur to maintain levels between 80 and 110. We will discuss with Emily that most women return to pre-pregnancy levels after delivery, but Emily will need to be screened every 3 years due to her family history and current gestational diabetes. Screenings can include a glycosylated hemoglobin, fasting blood glucose levels, or a 75-gram 2-hour oral glucose tolerance test.
That brings us to the end of the presentation on gestational diabetes mellitus. Thank you for listening, and if you have any questions, don't hesitate to let us know.